Well, hello there, amazing students, and welcome to week 3. This is Dr. J. We, of course, are talking about abnormal psychology, and this week we're going to talk about things from a little bit of a different perspective as we talk about biopsychosocial. But before we do, I want to introduce you to a couple of concepts outside of the course, outside of the book, and the readings this week that'll help to give you a deeper, more richer understanding of what we're talking about diagnostically. So we're going to talk about borderline pathology. Now, we've been talking about normal versus abnormal, which in some regard is clinical versus non-clinical, okay? We can look at patients, for example, who might have some challenges that might come to see a therapist, but is not necessarily a clinical patient. Okay, so kind of be of the mindset of that. And we're also going to talk about specifically today neurotic versus psychotic, and that's where we would fall into people going to therapy to get some help with some things versus the psychotic spectrum where maybe things aren't as helpful in therapy. Not so much the case, but particular to this one model, it might be. And so we're going to talk and introduce some of those concepts today, again, to give you a little deeper understanding. But before we do, as I have my little disclaimer here to talk about some of these things, we're going to talk about a concept called borderline. And in the context that we're going to use it today in this video, it's used as an adjective, not a noun, because some of you might be familiar with the noun borderline personality disorder. That would be an actual diagnostic term that we would use on a patient. They met that criteria, him or her, typically a her, by the way. But that is a noun context. In this particular context, we're going to use it as an adjective. It's a way to describe their structure, their diagnostic structure from a theoretical perspective. Borderline pathology is the stressors that the person has. It's typically defined by their coping mechanisms, their intact resources to handle those stressors. So the more intact resources, the higher order structures that they utilize to cope with stressors, we put them more in the neurotic range. If they're a little less organized, they're more on the psychotic range. And we'll talk about that here in a second, but it's a different way to look at pathology. And it's also a way to help you understand things on a deeper level. So in putting this together, gang, just so you know, this is a little bit deep in terms of the content, but I'm giving you the simplified version. And when I say the simplified version, it's not that I don't think you can understand it. It's just that I have to bridge the gap between this class and 5 other classes you were supposed to have. So it's just about creating a little bit of common language and understanding in the material. So bear with me, it'll all make sense. We've been talking about early diagnosis for the past couple of weeks. We talked about some of the ways that people would diagnose prior to the DSM, and we talked a lot about this from the medical perspective, from the biological perspective, if you will. But there were many different ways to diagnose a patient prior to the induction of the DSM. In fact, by the way, for only about maybe 30 or 40 years where we focused on an actual defined diagnostic model, there are many ways to diagnose a patient that were aside from those diagnostic models. They were more theory-based diagnosis of what a patient might look like or what might be happening for them. Sigmund Freud, as many of you know, probably recognize that picture, was the father we consider of psychoanalysis, and he certainly had a way to conceptualize a patient based upon a psychoanalytic model. Pathology manifests basically upon events in development. I mean, that was essentially the catalyst of psychoanalytic theory. Was there was a series of events that happened through a course of an individual's development that led to a particular condition, whatever that might be, would manifest something. If you look at this in today's term, this is more of the nurture part of what we're talking about, right? Because someone could be born one way or another, right? You might have a predisposition towards something, but if you're in an environment that's really harsh, that's where the nurturing part is absent, and more likely you'll have more pathology, okay? We're all talking about theory here, right? So Freud would say something like, tell me about your mother. And that's where we would start to investigate these types of things. And we talk about things in terms of neuroses or psychoses in psychoanalytic theory. We have what we call the neurotic spectrum. People are a little bit depressed. They would come in, they lay on the couch, they tell Freud all about their problems. He puffs on his cigar a couple of times, gives them a couple of reflections, a nice big fat bill, sends them on their way. They come back in a week and the story continues, okay? That's essentially what would happen in therapy with Sigmund Freud. On the other side of the spectrum, we had the psychotic spectrum, and these are essentially patients that didn't respond to psychoanalysis. In fact, in some cases, you can do some harm with patients in the psychotic range. Imagine if you have a patient who, for example, is very psychotic. They have a big thought disturbance. They're worried about people chasing after them, or worried, the paranoid thing going on, and now you're bringing up things about their past. You can actually injure them quite a bit in terms of emotional damage if you're trying to do any type of psychoanalysis with patients in the psychotic spectrum. And so this obviously is a little bit troubling for Freud, but certainly a lot of people out there to work with. Now, when we look at psychoanalysis, and we're talking about diagnostically where a patient might be, we're treating a patient, they respond to psychoanalysis, they're in the neurotic range. If they're not quite as well put together, we're still okay, right? They're still responding to therapy. But what would happen with the other part of the population that would be down here and weren't responsive to psychoanalysis? And we would try different things, and in some cases, again, we can cause damage. What about these patients that occasionally, based upon their intact resources, we would diagnose them as neurotic, but they had some things going on that suggested they were psychotic? What do you do then? Sometimes we would have these small little breakthroughs that would actually bring them down over time. Or if you can imagine perhaps someone who is sort of okay, we all know this friend, right? They're sort of okay, and then a big thing hits them. They lose their job, and it brings them down, right? Then they have a breakup, okay? And now they're camped out there for a while. Now maybe they get a little better and then a little worse, but things are falling apart. And now maybe they're not so, doing so well in terms of psychoanalytic therapy. Okay, so now it's time for something else. But generally speaking, those individuals would reside around a particular range. They're not neurotic, they're not psychotic, and that's where the challenge came in terms of psychoanalytic theory and certainly diagnosis. This is probably a better representation of what neurotic versus psychotic looks like, although there's not really a clear, distinct line when we're looking about one versus the other. If you can imagine things being very well organized, and as we get closer to the line, they start falling apart, and then as we get further from the line, they get more and more fractured, if you will. And so that's kind of the spectrum there, if you will. But I want you to start conceptualizing it in this way. We have neurotic on one end, we have psychotic on the other end, and in the middle we have what we would call a borderline range. And these are individuals that seemingly are put together on the surface, but they're kind of a mess inside, right? And I always jokingly say this with students, it's like we've all dated this person, right? Like they seem really great, but 6 months into it, they fall apart. Now, that could be true in terms of borderline personality disorder as well, and this is where things meld together sometimes. And so we're not talking about that. We're just talking about someone who doesn't really fit this particular range. And why is this important with what we're talking about? Because it's the catalyst of the social aspects, if you will, in terms of what we're doing this week in the class. We were talking about psychological phenomena. Early diagnosis were based on we have all these symptoms or we don't, right? They're called categorical constructs. And so what we would say is you have 5 of these 7, so you must have this disorder. That's very consistent with the medical model, right? You go to the doctor, they run a test, boom, you have this disorder. Categories are best when, okay, so we put people into categories diagnostically are best when you have distinct symptom sets, right? Again, consistent with the medical model, we run these tests. Test A, B, and C all say you have this bacteria infection. Here's the antibiotic. Boom. Okay, so categorical constructs work great in those environments. Symptoms are homogenetic, which means if you got a symptom, it has to be this, right? Is there anything in the DSM that is that? No, not hardly. Everything in the DSM is what we would call heterogenetic, meaning it can go anywhere. And there's no clear assessments for this. So we can give somebody diagnostically a assessment, and it might say they're depressed, but it also might have a little bit of anxiety in there. Incidentally, when we do diagnostics, we typically do what we call a battery. We'll do 5 or 6 different assessments to look at things from different perspectives. Categories are best to provide a structure, but may not account for the entirety of complex psychological phenomena. So you hear me a lot talking about in feedback, give me more depth. When we talk about the categorical constructs, it'll give you a black and white snapshot of what the individual is. It won't account for more complex phenomena. So what do we have? We have a biopsychosocial factor. We're looking at the genetic factors, exposure to certain toxins, things of that nature could certainly fall into those biological factors. But if somebody has a predisposition toward depression, for example, they're more likely to be depressed, or under certain circumstances, they may be more likely to be depressed, but it's not an absolute. We have emotional, trauma, abuse, environmental stress, okay? So we talk about that biopsychosocial thing. We have those emotional aspects that run into that, and of course that we have the social aspects where we have people, events, etc., that all factor into this diagnostic structure. Now, another concept, and you'll get into this as we progress a little bit, is a dimensional construct. And if you can imagine that diagnosis is based on a continuum where symptoms range from 0 to 100%. I want you to start getting in touch with the concept. We're all depressed. We're all anxious. Okay, we all have these within us. At times, we are more or less of some of these things. It doesn't mean we're clinical. It doesn't mean we're diagnosable. It doesn't mean we need treatment or medication. But if you've ever woken up in the morning and kind of laid in bed and thought to yourself, wow, I feel like calling in sick today. I just don't feel like going to work. It's probably because you might have been a little bit depressed. Okay? Maybe it was no big deal to take a day off. But if you took a week off, maybe that's a problem. And that's what we're talking about here. Best with heterogenetic symptom sets. We have symptoms that can go all over the spectrum. You can see depression-based symptoms in depression, obviously, within anxiety, within thought disorders. And so there's a lot of different places where you might see symptoms that are characteristic of one disorder in an entirely different disorder. And so can account for degrees of severity. And this is one of the biggest things that we want to look at when we're considering diagnostics is, as I said, everyone's depressed. Are we depressed at 10%? Are we depressed at 15%, at 20%, at 50%, at 100%? So when we look at things like bipolar disorder, for example, and we look at something like mania, we can say mania at a percentage, or we can say mania is present or absent, but we can look at different presentations and say yes or no on the different symptoms and their severity. And it recognizes the impact of the full spectrum. So as I said, in some cases, 7 out of 9 or 5 out of 9 in terms of diagnostic criteria won't tell us as much as if we say 10% of this, 50% of this, 70% of this, etc. One of the biggest things that I like to talk about in dimensional, and certainly talk about in writings, gang, is more nuance. We want to have a bigger, richer understanding of the phenomena, not just a quick snapshot, because that helps us more in terms of treatment planning. So with that, welcome to week 3, right? Let's take a look at the assignments for this week so that I can help you get on track in terms of your submissions. And so this week we're going to identify the diagnosis based on main diagnostic features. And why was all that important? Well, because we're going to discuss how symptoms are shared between different disorders. And so disorders have similar symptom sets, and sometimes it's important to tease out what that particular disorder is. That could be particularly important when we're talking about things like medications or treatment planning. And so it is important to understand the foundation of how this occurs. And that's why you want to go deeper with your diagnostic studies. Now, in terms of the readings this week, very important, keep up on your readings. If you do, this stuff will be easier for you. And I know sometimes it's like, well, I can take a shortcut and I can skip these readings, or, oh, I don't need to read this, or, oh, I did fine last week and I didn't do all the readings. That's fine, but keep in mind, you are going to have assessments in your future, like psychological exams, board exams, things of that nature. And if you know this stuff inside and out, no problem. If you don't, then one day you are going to struggle with these things that's going to help you move forward in your career. So make sure you're taking the time, putting the energy in, because you'll have a deeper understanding of this. I'll talk about this in terms of planning for your assessments as well, but make sure that you're doing the reading. In particular, there's some things that talk about the particular disorders. What is bipolar disorder, childhood trauma, depression, and so forth. And as we get into some of the assignment this week, you'll have an opportunity to kind of pick something and run with it. So hold that thought, research on particular disorders, and I'll come back to that in a second as we move on with the submissions. Now, for the discussions this week, you're going to talk about this balance that exists between the sympathetic and the parasympathetic nervous system. I mean, that's one of the biggest things that we're going to start with. So we're going to talk about the fight or flight phenomena, which we're going to see something as an extreme and we're going to choose to run from it, or we might be totally freaked out and overwhelmed from it. We might shut down. We're going to talk about anxiety and phobias from this perspective. Again, thinking back to what we just read about, if we just read about these concepts and watch these videos and have this information fresh in our mind, this is going to be really, really simple, gang. So make sure that you're doing that. Now, one of the things to keep in mind on the discussion board, folks, it's a discussion, right? It's just like an in-class discussion. So respond to your peers. Post it early in the week so that people have time to read over them and post replies back to you. When you do discussion posts on Sunday afternoon and miss that deadline, nobody can read your posts and we all kind of move on without discussing things, right? So post early in the week, post by Tuesday or Wednesday each week to have it done. Do those replies, like do one at the same time you're doing your main post, maybe do the next reply the next day. Have it completely off your plate, because I gotta be honest. Main discussion posts will probably take you a little bit of time to put together. That's true in every class, but those replies can't take more than 15 or 20 minutes a piece at most. And so that's a 30-minute task that many students put off until Sunday night at 9:30 p.m. Don't do that. Do it early. Do your main post. Be done with discussion boards by Friday. You can move on. So let's talk about the week 3 assignment this week, because we're going to have a journal activity. And so I want you to think in terms of, usually I allow journals to be a little bit more off the top of your head, a little more touching in terms of your thoughts, feelings, and ideas. But I want you to get comfortable pulling the research into what you're talking about. So this week you're going to have an opportunity. It's a case study example, if you will, where you're going to have a person that has experienced some level of trauma, and it's going to give you a scenario where you can choose from a list, if you will, of anxiety, depression, dissociative disorders, mania, obsessive compulsive, etc. So in other words, you can go down a diagnostic path with something that interests you. Ding, ding, ding. Diagnosis, research. Oh yeah, we just did some readings on this exact stuff. So it should be very easy for you to talk about anxiety, considering you just read an article from this week's required readings about anxiety, not to mention the textbook. Do you see where I'm going with this, gang? So you should have a good understanding when you're answering these questions from that perspective. Now, lastly, let me just back up for a second. Make sure to integrate a little bit of that into what you're talking about. You don't have to get super detailed in this stuff. You're going to answer some questions related to the journal. It's going to ask you a few different questions. So just write maybe a short paragraph for each one of those responses. I think there's like 3 or 4 of them. So you're going to have like about a page and a half-ish, maybe 2 pages. in your journal. But again, if you've done the readings, it should be super simple for you to pull this information together, okay? Last but not least, I want to talk about Project 1 because it is a coming. Okay, so make sure, put in the time and energy this week into your readings. If you've done that the last couple of weeks, the Project 1 should be very easy for you to put together this week. So make sure you're doing that. So let me know if you have any questions. And if you get done with this week, go ahead and get a jump start on next week. I always tell students it's fine to work ahead. Just don't work ahead on discussions. Only do discussions during the week assigned, both a main post and a reply. You can do your main post early, just write it in Microsoft Word and hold it till Monday morning. So with that, gang, I am traveling this week, so doing a lot, got a lot going on, but as always, happy and excited to work with students and coach you. Be working on grades here and have those back up and posted to you in the next couple of days. Make sure you're reading your grading feedback. Reach out to me if you have some questions. Hope you enjoyed this presentation. Hope you found it of value. Reach out if you have some questions about any of it. I look forward to seeing your posts this week on the discussion board and your submissions. Everybody have a great week.